So what I really want to know is, so once you know that there's a problem, you decided that you're going to intervene, you take them to the operating room or the lab, sorry. And I kind of want to just like pick your brain about like your algorithm, like how you start from access,
Okay.
like what your venogram looks like. And then like once you see the lesion, like I want to know like everything you're treating with. Okay, go ahead.
So what we do is we take them to the back, right? And based on the physical exam, I pretty much know, and like Ari, we've done this a long time, and we've done thousands and thousands of these cases. We can pretty much tell you exactly where the lesion is and how much it is before we even shoot the angiogram.
Yeah,
It's just,
using your sixth or maybe seventh sense.
I mean, it is. We can tell you the flow. When you do it this much, it's almost scary that you're like, wow, I hit that number, right?
Okay.
I think Ari and I were talking about at a meeting once about, can you guess flow rates before the ultrasound gets it, right? And it's scary. Sometimes I've hit it on the money, which is scary.
I believe this.
And I'm sure Ari's done the same thing. But yeah, so we take them to the back and we will first get them on the table, and it basically insert a needle to gain access. We'll put a wire in, and then we'll put what's called a sheath into the fistula, which is, I call it kind of like a little manhole. It gives us access to the lumen of the access, the fistula or the graft. All right. We will shoot contrast or dye through that port, which will basically trace the blood flow from the port all the way to the central vessels. And it's like looking at a map. I don't know if Ari, I don't have any images right here with me, but I'm sure we'll pull some up in a little bit.
We'll show some at the end for sure.
Yeah,
so
when you shoot, it's obvious. I mean, I've had high school students come in and, hey, where's the blockage? And they can just point at it. And I mean, you get something that's wide, then it goes that wide. And so once we see the blockage, we identify the lesion. There's two things we can do. Because we've done this a lot, we can size the vessel just by eyeing it. That's one way we measure. The other way we measure is IVUS, which is intravascular ultrasound. We will basically put this little small catheter up and pull it back through the access, and it will show us the everything within the lumen. You will see the intimal hyperplasia, which is the area of stenosis. You will see the normal vessel, and we will get a measurement of the normal vessel, and then we'll get a measurement of the stenosis. And then that will give us a percentage of that stenosis compared to the normal vessel. And that's how we pick the balloon. We know we need to balloon it, okay?
Are you using IVUS on every patient or?
If I've just done the patient.
Sure. Okay.
Recently, no. If I know the patient well and it doesn't look like there's a change in size, or if there's a discrepancy in what we see, you have to remember that angiograms are two-dimensional, okay? They're not three-dimensional. You can turn the cameras and get different views. So you can miss stenoses that are present at times in difficult cases. But no, we don't use IVUS on every case, but it does help us out. It ensures that we pick the right balloon size, and it also gives us a measurement of the degree of stenosis in the patient. Or sometimes we see that there's thrombus present, things that we need to know that are there that we don't want to send to the lungs. So IVUS is a valuable tool in that sense. So once we pick the balloon size, and this is in my lab, I'm in an OBL setting. If I was in a ASC setting, there's other things that we could do to prep the vessel or the lesion before that. So in an OBL setting, and I'll let Ari will kind of talk about what he can do in the ambulatory surgery center or hospital setting. I will pick a balloon, and we will insert the balloon in right at the area of stenosis and inflate it until we get what we call full effacement. That's where the balloon is completely open, right? There's no kinks in it. The balloon is blown up into a full circle, right? And if you're looking at it in cross-section. And then I like to hold my balloons open for about 2 minutes in access. It's just, we call it scaffolding. And it's kind of like, you go up and you hold it a while. It ensures that any of the intimal hyperplasia or any of the scar tissue is really torn open. And some of the lesions that we deal with, we call them elastic. So they don't just snap or tear open, they kind of stretch. And so the longer you leave that balloon up, the more those fibers are damaged, or that tissue is damaged so that it remains open.
All right. And then balloon pull down, repeat venogram, and
Yeah, so we'll deflate the balloon and pull the balloon out. We'll shoot a second shot. And there's a couple things we look for. Number one, we look for just the obvious, right? Did it go from this tiny to back open, right? And then you look at the flow, the general flow rate. So we'll shoot and make sure that blood is flowing very briskly up through that area. And the other thing, you just lay your hand on the fistula and the pulse should have gone away. And what a pulse is, when you feel a pulsatile access, what we're talking about is the quality of the pressure that's resonating to your hand, okay? A pulse is indicative of very high resistance, okay? So it's kind of like if you're running into me and I'm standing there, but I weigh, 300 pounds, the moment you hit me and bounce off, that's a pulse, okay? If you run again, you hit me again, you bounce off. But if I get out your way and you run right by me and you just whoosh by me and keep moving freely, that is what we call a thrill. The other way I say it's like kicking a skateboard that's got rusty wheels is a pulse versus kicking a brand new skateboard. As soon as you kick it, it's going to keep rolling, right? So we ensure that the pulse goes away and that it has a thrill and that it's a nice soft fistula. So those are a few of the things we look at as soon as we've angioplastied to ensure that our post result is good. That, do we have good flow? Is it without resistance? Is the lesion open? And then at times we look for it. Did we have any significant damage, like a dissection? That's where the layers, the intimal layers, or between the within the vein have torn, and there's bleeding between them. And then you can also have a rupture, which is where the vessel tears completely through and you have hemorrhage into the tissue. If that occurs, we'll put the balloon back up, hold it for another, couple minutes, let it back down and see if it resolved on its own. I really like in fistulas for these to resolve on their own. There are cases where they don't, and that's where we will look at putting a stent in.
Sure, no doubt. But like you said, best if you can avoid like the no metal left behind approach for a rupture.
Yeah.
Totally agree.
Yeah.
Yes.